Okay, welcome to today's webinar on the National Academy of Sciences, Engineering, and Medicine on Primary Care's report on implementing high-quality primary care, rebuilding the foundation of healthcare. This webinar is co-sponsored by the Center for Primary Care at Harvard Medical School and Ariadne Labs. My name is Russ Phillips. I'm a practicing primary care physician, and I have the privilege of directing the Center for Primary Care. To give some background on the center, our mission is to create a community at Harvard Medical School that promotes equity, resilience, and value in primary care to improve lives. And we work in areas of research, education, and innovation with a focus on medical education and leadership, student-led programming, practice redesign and entrepreneurship, advocacy and equity, and policy-relevant research. In a moment, the Dean of Harvard Medical School, Dean George Daly, will introduce the session and speakers. Each speaker will speak for a short time and then pass the microphone to the next speaker. Our speakers will be focusing on the role of payment and equity on the committee's recommendations. Please mute yourself so as to not interrupt the speakers, but feel free to use the chat button to make comments or ask questions. The speakers will try to respond to the chat in real time once they've spoken. Once the speakers are finished, we hope to have a vigorous discussion. I will now turn it over to our dean, who is excited about primary care and the work that we do, is very excited about the NASEM report, and has been extremely supportive of both the Center for Primary Care and Ariadne Labs.
Welcome to this webinar entitled Paying for Primary Care to Achieve Equity, the National Academy of Sciences, Engineering, and Medicine report. I'm George Daly, the Dean of Harvard Medical School, and this presentation is being sponsored by the Center for Primary Care at Harvard Medical School in collaboration with Ariadne Labs, and will be moderated by Russ Phillips, the Director of our Center for Primary Care. With us today as presenters are two members of the National Academy Committee that generated the report we will be discussing. Bob Phillips is co-chair of the committee, and Kerry Kalla is a member of the committee. I'm pleased to say that Bob is a member of the Center for Primary Care's research group, as is another member of the National Academy Committee, Asaf Bitton. Briefly, the committee made 5 recommendations. Number 1, pay for primary care teams to care for people, not physicians to deliver services. 2, ensure that high quality primary care is available to every individual and family in every community. 3, train primary care teams where people live and work. 4, design information technology that serves patients, their families, and the interprofessional primary care team. And 5, ensure that high-quality primary care is implemented. Today, we'll be focusing on the recommendations on payment for primary care. First, I want to emphasize that I came to my role as dean as a physician scientist pursuing fundamental studies of stem cells and cancer, and as past director of the Dana-Farber Cancer Institute, Boston Children's Hospital Pediatric Bone Marrow Transplant Program. However, despite being steeped in quaternary care, as dean, I have come to learn and to believe deeply in the value of primary care. Primary care improves care quality, reduces costs, and in work done by our center, improves life expectancy. I also believe that the primary care system in our country is in crisis, with not enough primary care physicians being trained and declining numbers of established primary care physicians in the community. The center's own work suggested that almost 100,000 primary care physicians are needed to achieve equity in life expectancy in this country if we are to meet the needs of all those who live in underserved counties. At Harvard, we've made a strong commitment to primary care through the work of the Center for Primary Care and the strong divisions of primary care in place at our affiliated hospitals. We have thousands of primary care faculty across our hospitals, and I want to do all I can to support their critically important work. I'm also pleased to share that through the work that we are doing at Harvard, we have moved up in the US News and World Report rankings of primary care medical schools from number 15 some years ago to now ranking 8, and we aspire to do even better because I firmly believe that Harvard Medical School has a tremendous amount to offer to advance the cause of primary care and to elevate its stature in medicine. Most experts agree that as payment goes, so goes both primary care and its ability to improve equity in healthcare and population outcomes. Primary care is underpaid relative to comparison countries, and a lack of resources is often cited by those primary care physicians who leave primary care practice. In the United States, only 5 to 6% of healthcare dollars fund the foundational work of primary care, which is only a third of what is provided to primary care in comparison countries. The center's work suggested that capitation or prospective payment will lead to high value care, while fee-for-service is wasteful and encourages overuse of services. This work was cited by the committee in its conclusions that primary care should move towards a capitated payment structure, perhaps initially as a hybrid with fee-for-service. Today, we will hear Bob and Carrie talk about the committee's findings, and even more importantly, the implementation plan around changes in payment. Bob is a family physician and a researcher and leads the Center for Professionalism and Value in Healthcare at the American Board of Family Medicine. Carrie is a PhD researcher at Dartmouth who focuses her work on payment and health policy. We will hear reactions from Alan Gorel, a primary care general internist and member of the Harvard faculty, who has spent much of his lengthy career thinking about and studying payment. We will also hear from Wayne Altman, chair of family medicine at Tufts, who will talk about a new payment strategy for Massachusetts. And we will then hear from Ann Greiner, the executive director of the Patient-Centered Primary Care Collaborative in Washington. She and her organization have focused on increasing payment for primary care. Given the importance of equity, I'm particularly interested in learning how the speakers believe that changes in primary care payment can help us achieve equity during these challenging times. With that, I turn things over to Bob Phillips, our first speaker.
Dean Daly, thanks so much for that kind introduction. I'm going to share my screen. There we go. I'm going to be brief about the front of this conversation because I know we want to get to the conversation about payment. So I'm going to offer a little bit of context. And for those who haven't seen a presentation about this report, forgive me if I am brief. We're happy to back up and have some more contextual conversations, but we really want to get to the heart of the conversation. So know that this committee of the National Academies was made up of 20 individuals, as well as 3 fellows, supported by a very robust staff. Those 20 members included several types of clinicians, including physicians, nurses, dentists, pharmacists, and PAs. We also had the executive director of a community health worker program, CEO of one of the largest federally qualified health centers in Texas, state and federal health policy experts, an economist, 2 anthropologists, and a sociologist to really give a fair representation of the kind of robust primary care team we're looking for and how to support it. We also had 17 sponsors, including 4 federal agencies, several philanthropies, and most of the primary care clinician, or at least physician organizations in the country. So we had a lot of stakeholders who had an active interest in shaping our statement of task and now in how to implement it. Our plan our statement of task actually had three important things. One was the effort to build on the 1996 IOM report on primary care. The last one that the National Academies did focused exclusively on primary care, which landed during a time of, actually started during a time of health reform and excitement about primary care, and landed as those things were waning. And so many of the recommendations didn't actually get traction. So our goal was to build on that and contextualize it for a more modern time. The second was to present a face of the report for international consumption and to help us as a country in those international conversations, which right now are very focused on primary health care. The third component, which is very unique to National Academies reports, was a requirement to develop an implementation plan. So not just recommendations, but the capacity to name actors and actions that might make the recommendations stick. Of the process, the thing I want to emphasize is that we had 16 peer reviewers, also very unusual for an Academies report. So we had lots of input into improving the report. The good news is that they had no changes to make to our recommendations. The committee was not asked to relitigate the evidence for primary care, which even by 96 was quite clear. We did update it, however, and the studies that have come out since only serve to support the previous evidence. And Dr. Daly pointed to the important work of the Harvard Center for Primary Care and shoring that up. But notably, that primary care is the only part of the healthcare system that results in longer lives and better equity for the population of the country. And as Dr. Daly said, it is weakening. We are seeing active erosion of primary care clinicians of all types, particularly in underserved and rural areas. And there are bright spots in the country, and we highlight several of those in the report and talk about how important it is to scale those. And that's what our recommendations really are focusing on. One of the key other findings of the report that's important for folks to know, because it's relative to this discussion of payment, is the fact that primary care, while it serves more than a third of all healthcare visits in this country, gets only 5% of total healthcare spend. And it's left it quite anemic in its capacity to serve that health equity role and to bring a broader, more comprehensive set of services to everyone. The COVID-19 pandemic really served as a lens for us in identifying problems for primary care, most notably that there's no federal champion for primary care. There's no federal agency dedicated to primary care. HHS does not have a centralizing focus. And that showed up in spades in the fact that primary care was not mentioned in our national epidemic plans, and therefore was not a strategy in specifically a focus of support in any of the congressional relief bills. And it's only been in the last few months that it has been brought into the vaccination strategy. So it was an important lens to have. And we have lots of evidence, some from our colleagues at Harvard, showing that primary care practices have struggled during this time. Being largely dependent on fee-for-service, they saw severe reductions in their visit volumes and therefore maybe at some financial risk for some time to come, right at the very time that we need them to help take care of the population as it comes back from the pandemic. The 96 report began actually with a 94 publication of a definition of primary care, and our committee actually started there as well, so that we had a shared concept of what we were talking about, and also with the idea that it probably needed to be updated from 96. And so you see focus in this description on the capacity for taking care of all of someone's needs. So this idea of comprehensiveness, the idea that this often delivered in teams, but with members of the teams accountable for the relationships that we know have therapeutic effect, and that the focus of primary care is is on the patient, but in the context of family and community. And in fact, we want to enable primary care to get back to its roots of community-oriented primary care and its capacity to take care of communities. That population health function means reaching beyond the walls of our clinics. And so the financing mechanisms we're talking about are really aimed at trying to enable this definition of primary care, which we don't find in many places in the United States. And another overarching idea that the payment recommendations are targeting is this idea of primary care as a common good, that it needs to be accessible to everyone in the population because it has such high societal value, and that process needs public oversight and monitoring. It needs that champion at the federal level and needs strong advocacy among the stakeholders, including the public and clinician organizations. The recommendations really target all three levels of the healthcare system. We have built-in mechanisms for accountability, notably a scorecard and who should be tracking that scorecard to ensure that the recommendations are being implemented and are having effect. We believe we have a really good policy window right now with concern about the future of the US healthcare system, about a focus on health equity, and about what the COVID-19 pandemic has really revealed about our healthcare system and notably about primary care. There's also a window opening around infrastructure that we think primary care can be linked to, but health equity really is the leading policy window we think is relevant here. And as Dr. Daly outlined, we have 5 overarching objectives. The first one is payment, and that's the focus today. There are also objectives around access, workforce, and digital health. And Dean Daly really went through each of these, so I won't belabor that. But the payment process is just so critical to enabling the rest of them that I'm so glad it's the focus of our conversation today. And I'm happy to turn it over to my colleague, Carrie Kalla, for the next round.
Thanks, Bob. And thank you to this group, both for the invitation and to the attendees and speakers for your engagement in this important work. I'm happy to share the committee's recommendations on primary care payment with you. As Dr. Daly mentioned, I'm Carrie Kalla, a health economist and professor at the Dartmouth Institute for Health Policy and Clinical Practice at Dartmouth College. The committee's vision for payment was a daunting one, a low-burden payment model that would enable sustainable, team and relationship-based, high-quality integrated primary care. It would allow all people to have ready access to primary care teams across modalities, and it would assist people in addressing the social determinants of health. Primary care payment needed to be adequate to support high-quality, independent primary care practices and flexible enough to support an emerging array of new delivery models. Next slide, Bob, thanks. So we have 4 actions around primary care payment for implementation steps or recommendations. The first one is that payers, including Medicare and Medicaid, should evaluate and disseminate payment models based on their ability to promote the delivery of high-quality primary care, not only short-term cost savings. Other goals of primary care payment that should prompt model dissemination include support for the patient experience, improvements in health, support for different types of providers across communities and geographies, such as rurality, health equity, stability through shocks such as this pandemic, and clinician satisfaction and reductions in burnout. I know these goals are similar to many of the ones that you've espoused for Massachusetts primary care. Action 1.2, we know that fee-for-service models discourage successful engagement of primary care practices in structure and process improvements and care integration. And as we've seen this past year, fee-for-service models are also unable to withstand volume shocks. The committee recommends a multi-payer shift away from pure fee-for-service, which still makes up roughly 85% of primary care payment, and move to a hybrid default payment model. We recommend use of part fee-for-service, part capitation for primary care, where fee-for-service is used in the case of services we want to encourage as clinicians gain experience with the model. The payment model needs to be consistent across payers to motivate change and to simplify the reimbursement environment. The primary care payment model should have 4 characteristics. First, it should support interprofessional integrated team-based care. Second, it should be risk adjusted for medical and social complexity. Third, it should allow for investment in practice transformation and infrastructure. And fourth, it should align incentives to measure and improve outcomes. Based on a Green Center poll during the pandemic led by committee member Rebecca Lutz, 3/4 of primary care physicians do not believe fee-for-service should account for the majority of primary care payment. Slide, Bob, thanks. Many have asked us why a hybrid model? Why not go further to full capitation? First, mixed reimbursement models balance incentives inherent in both capitated and fee-for-service models, such as do more or do less. Second, we wanted to be pragmatic, and our goal is to change the default setting, to bring up the base and to start a transition away from fee-for-service. There are some services that it is good to continue to pay for, so they should continue to be done, so that they continue to be done in primary care and not pushed out to specialists as well. So we should continue to pay for those under fee-for-service. Of note, the committee also recommended that for larger providers already engaged in population-based risk-bearing contracts between the delivery system and a payer, such as capitated contracts or ACOs, payers should ensure that sufficient resources and incentives in those systems flow to primary care. We are not recommending that clinicians comfortable in these models shift to more hybrid models, rather to bring those in pure fee-for-service away from that extreme. Next slide. Thanks. As I mentioned, multi-payer collaboration is key to changing payment. I know Massachusetts is aiming for this, and states and Medicare can play important roles as conveners, encouraging self-insured employers to participate and to provide forums for provider learning. Next slide. Action 1.3. Despite recommending this move away from fee-for-service, the Medicare physician fee schedule retains an important role in our payment system as it is used by many payers and often is the basis to calculate capitated payments. Currently, the American Medical Association's Multi-Specialty Relative Value Scale Update Committee, colloquially known as the RUC, plays an influential role in describing the resources required to provide various physician services. Based on reliance on the RUC, through mechanisms described in detail in the report, primary care has become consistently devalued over time in the physician fee schedule. We recommend the CMS create and invest in independent data collection, valuation tools, and expert panels to identify overpriced services while maintaining budget neutrality. The value of a new process to evaluate the fee schedule could also be supported through the appropriations process. Action 1.4. The support of states is pivotal in implementing the changes recommended by the committee, using their authority to facilitate multi-payer collaboration and measuring and supporting an increasing portion of healthcare spending to primary care. Next slide. States can serve as conveners, take state action immunity, as I believe Massachusetts did with its patient-centered medical home model, set standards for marketplace plans, or measure and set goals for primary care spend. Several states have already taken leadership in this area by passing legislation or issuing executive orders, such as Rhode Island, Delaware, Utah, Colorado, Oregon, Connecticut, Vermont, and Washington, as we'll see. Next slide. In summary, the committee recommends a complete phase out of pure fee-for-service in primary care, shifting the default to hybrid payment models with patient assignment to primary care teams and adequate resources for transformation. We expect the combination of some downside risk, a revaluation of evaluation and management services, and health system accountability to translate to sufficient resources to implement high quality primary care. Next slide. As you all know, there are many barriers to implementation of these recommendations. I hope our discussion will focus on how to overcome them. Now over to you, Alan. Thanks. You're on mute.
How about now?
Good.
Perfect.
Thanks.
Very good. I have a student who's seeing a patient right now, so if you saw me looking the other way, it's because I was precepting at the same time. A life of primary care as we all know it. This is a wonderful report. I spent the last 2 nights muting the news and reading the report. and I recommend especially the payment section to everybody. It is thoughtful. It is a superb review of the literature and the evidence. It's excellent. But I want to critique one part. Its focus, and I think the focus of, and it's a reasonable focus, is to be pragmatic and bring up the base. And remember that much of the base that still is here, it's similar to the last generation of airplane pilots that are about to retire. Much of the base got burned during the last iteration of capitation. Let's call it capitation 1.0. And the consequence of that is that there's a lot of reluctance to move from fee-for-service. So what I'm hoping is, in addition to a strategy of bringing up the base, that we could all, are you getting feedback on my voice here? Okay, good. I am getting it, so I just want to be sure it's not happening. So what I'd like to suggest is another section of the report, maybe an addendum. And that is, we're going to have a generational shift in primary care workforce. In fact, we're right at it at that point now. And many of the people who are very reluctant to move to capitation because capitation 1.0 was not risk adjusted, there was no investment, and in fact, all that one did was pay on a PMPM what people were paid on a fee-for-service basis, with risk transferred from insurers to the primary care group. So they react almost emotionally and very negatively to any suggestion we revisit prospective payment. I would suggest that we have a second component to the strategy, which I'll call an aspirational component. There are many practices made up of younger clinicians, a new generation of primary care doctors. Zuri was my student, and he's now in our practice. And the irony was, until this year, he came into a practice that was stayed exactly the same way it was when RBRVS was invented. I'd like to turn his generation loose. And I would like the report to have an aspirational component that would unlock the creativity, the thoughtfulness, and the mission-drivenness of this generation that's coming up. I got into payment reform because it broke my heart to see good students like Zuri choosing procedural specialties. I'm not a health economist. I am not a health services researcher. I'm basically a medical educator. And this is how I got into payment reform, because my students would come in at the day of writing a recommendation letter and they wouldn't make eye contact anymore, although 6 months before they had a great time. And they loved the concept of primary care as they saw it practiced here. So I'd like to urge those who are involved in the report to write a coda, but also that we have an actionable plan for turning loose that creative energy. Because I am very concerned about career choice, and I do not think that bringing up the base is going to change career choice. So let me stop there and turn it over to Wayne, but I would like to continue that conversation during the Q&A if we could.
Thanks so much, Alan, and thank you, Russ, for inviting me to be here. I'm honored to be here with all of you. This report is extraordinary. It really highlights the fact that a priority around high quality primary care available to everybody in the United States is the consensus. And that was not a foregone conclusion years ago, decades ago. And we have an extraordinary opportunity to make non-incremental change at this moment, because I, like Alan, am also extremely worried about primary care choice. And I think one of the greatest crises in our healthcare system is primary care that is inadequately funded and inadequately staffed. And when we have more primary care, we know we have better outcomes, and we know we have less equity. And there's another crisis that people have become increasingly aware of, which is the lack of equity in healthcare and the structural racism that is part of our healthcare system. And primary care is a huge part of the antidote of the equity issues and the structural racism issues. And unless we come up with a way to inspire students to choose family medicine and primary care, we are going to continue to be in the trouble that we are in right now. And there's some good data from many years ago that looks at the ratio of salary of the average primary care doc and the average specialist. And when you plot that ratio over decades and you plot the rate of students choosing primary care, they are parallel lines. They go up and down with each other. And so it's a fairly simple analysis. Loan repayment is a pretty impotent lever at generating student choice. Increasing salaries in primary care is a potent one, not a marketable one. As health policy people standing up in front of the public saying we must pay doctors more is not the most popular marketing strategy, but it needs to be a side effect of what we're doing. And we have been working in Massachusetts. We formed a group, many of who are here with me are part of this group, called the Massachusetts Primary Care Alliance for Patients, MAPCAT. And we have been focused on two things: doubling primary care investment and shifting from the ills of fee-for-service towards a prospective global payment for primary care, and doing it in an equitable way. With regard to equity, when you think about risk determination, applying the neighborhood stress score, which was developed by Dr. Arlene Ash at UMass, or something similar to that, to reallocate resources to allow for social determinants of health. And that would be a large step in the right direction in terms of addressing structural racism. Evaluating quality through patient-centered measures that are really focused on patient experience, such as Becca Etz's PCPCM measure, which is quite extraordinary. And also using a very small number of quality measures that are really focused on primary care that we like to call power measures, patient-oriented with evidence required. So we have been working on legislation in Massachusetts with State Senator Cindy Friedman, who's chair of healthcare finance in the Massachusetts State Senate, that would accomplish these things, that would accomplish primary care as a common good. This expression, this is being used over and over again, which is just extraordinary. And when primary care is a common good, there are no copays, there are no deductibles. And insurance really doesn't belong connected to primary care, because you insure for unexpected poor outcomes. You don't insure for something that you want everybody to have and that everybody needs in order to generate better health and better equity. And so what we're struggling with and working with is to try and figure out the funds flow of how to make this work. One of the ideas that we've toyed with is the idea of a state trust that would pay for all primary care in the state, that is potentially funded by a tax that comes to employers and payers, and they would end up paying the same or perhaps less than they were already being paid for primary care, paying for primary care. So it would be budget neutral, perhaps even value added, even though the word tax is not popular. And by funding it this way, it helps the ERISA problem and allows for a global payment for all of primary care in the entire state. And I will leave it there. I know there are lots of questions and lots of good discussion to be had, so I think we should preserve the rest of the time for good discussion. But before that, I'll hand it over to Ann Greiner from the Primary Care Collaborative.
Thanks so much, Wayne, and thank you, Russ, for the invitation to be here today amongst a lot of friends all working to make primary care more robust. To me, it was very exciting to see that the NASEM report payment recommendations focused both on how we pay and how much we pay. Because at the Primary Care Collaborative, which is an organization that's been around for about a dozen years and has focused on the patient-centered medical home, we came to the conclusion about 3 or 4 years ago that the model simply was underpowered. And, you know, there's a lot of reasons why, but we think that 2 principal reasons is that most practices are still paid fee for service, as Carrie pointed out. And we've been slowly but surely underinvesting in primary care. And by that, I mean the percentage that we spend on primary care as a percentage of total cost of care has been declining. We put out a study last year that based on more recent data, 2017 to 2019, both national and at the 50 state level, and we saw that decline in the majority of states and also at the national level. And then other studies showed that decline going back, you know, all the way to 2002, a decline. So, you know, at a time when our health expectancy is going down, and we know that the health of the population is not improving, we're investing less in the very part of the infrastructure that could actually address these problems. And one of the points that I love in the NASEM report is that this is the one part of the health system that if we put more resources into, we could get better outcomes. I mean, you know, that's just amazing. And so we have to, I think, get that message to the highest levels and beyond the primary care community, you know, to the White House and to major decision makers in order to get some seismic change, if you will. You know, the news about declining primary care investment was before, this was all data before COVID. And then, you know, studies that have come out of the Harvard Center for Primary Care and other places, you know, really are a 1-2 punch because we've had a hell of a year. I think a study that Bob and Asaf and others were involved in showed that an estimate of a $15 billion loss in primary care revenue in 2020. Wow. So the platform was already in trouble, and then we've just had a very, very tough year. Carrie mentioned work that's been going on for the PCC since 2018, but really going much further back under the leadership first of Chris Kohler in Rhode Island, for states to look at what they're spending on primary care. And now there are 13 states that are reporting primary care spend or are poised to do so. And this kind of report these kinds of reports that across all payers enable a conversation at the state level about the priorities with respect to spending, because as you know, a budget really reflects your priorities. So, you know, the question around multi-stakeholder tables at these states around, you know, are we getting value for our expenditures? Does it reflect what we're trying to achieve in terms of enhancing the population health, reducing inequities. And I think that these decision makers at the state level are concluding, well, no, our expenditures don't reflect what we're trying to achieve. And so half of those states, once they have done these reports, have taken steps to set targets for increasing primary care investment. And that is very, very exciting. And Massachusetts is one of those states. And I remember meeting with Wayne and Russ when they were beginning that work a couple of years back. So it's exciting that states are taking that step, but I think the NASEM report has recognized that that is a multi-year process, and it can't, not all the states are going to take it up, and it can't move quickly enough to address the crisis that we have in primary care. So the other recommendation around targeting CMS, and potentially they need more authority to focus on the fee-for-service, the process for setting the rates in the fee-for-service system, payment system, the RUC, is also a really important recommendation, and also, frankly, a steep climb. That revaluing during a period before we hopefully achieve a completely reformed payment system that is much closer to total capitation is very important. Also, Carrie did underscore that, that valuing is used to set the stage for the capitation system. So it is really important, and also that's going to be a heavy lift. So I think that we have to continue the work at the state level in terms of more investment, but I think primary care needs to build a very, very broad coalition, likely of strange bedfellows, because that's how effective coalitions work, to get the Biden administration to put primary care high up on its agenda, because it has made it clear, the administration has made it clear that it wants to address health inequities, and primary care is a vital way to do that. I don't think it's just going to be the administration, though. I also think we're going to need to convince those on the Hill about the importance of our agenda. So I want to just close by really thanking not only the committee that produced such a fabulous report and a great jumping off point for us to move this agenda forward, but also just really compliment the work of the Harvard Center for Primary Care, because we use your work all the time in our education and advocacy, and it's just such important work. So thank you so much.
Okay, thank you so much to all the speakers, especially to the authors of the report. I certainly agree it was an astonishing and stunning and wonderful display of both wisdom, knowledge, and it was a great review of the field and where we need to go. Thank you also to our respondents. I thought this was a really interesting discussion. I have several of my own questions, but I think I'd prefer to go to the questions that are have shown up in the chat. There's one question about family physicians who might have some resistance to changing a practice to a more advanced model of primary care, and wondering about how we will accommodate those physicians in a new payment or practice model, and whether there's room for them to continue to be paid fee for service even as we move towards a hybrid model. And I wonder maybe if the committee members, maybe Carrie or Bob, could talk about their thoughts about how to accommodate physicians who don't feel ready to succeed under new models of payment.
Well, I think we need to support them to make the switch, but I think they need to make the switch. And I think as long as it's a long-term commitment by the payers, and CMS in particular, that this is a permanent switch, that it's not a temporary thing that they need to learn and invest in and then is going to go away. There might be more cooperation, but I think it needs to be a little bit of a push, I guess is my opinion.
Okay, great. Thank you.
Russ, if I
Florence,
could-
oh, sorry. Go ahead, Bob.
No, this is Wayne. Just very quickly, I think that in the past, changing payment mechanism was never accompanied by increasing primary care investment. And when you accompany it with increasing primary care investment and you're actually getting a raise, I think there'll be much less resistance. If the payment is right, I think people are going to be willing to change.
Yeah, throughout the report, we've said pay differently and pay more. And I would also say the payer support is important, particularly around attribution or who their patients are. That's something that physicians get really nervous about. Who are they responsible for? And so sort of technical support in those ways will be really important.
I think those are both right. And I think one of the things that Carrie said about give them some faith that it's going to be around for a while. They've been whipsawed by a lot of the payment demonstrations, and the transformations they make are often funded by them with the expectation that payments will come behind and fill their investment. And I'm not sure that expectation has been met frequently enough that they have faith that it's going to happen. The other thing I would suggest is having transformation support. This month's Annals of Family Medicine has a great report out of the evaluation team escalates of the AHRQ funded Evidence Now demonstration project. And it really suggests that practices need support. They need coaches, they need guidance, they need someone pointing to examples to help them make that transition while they're also taking care of all of their patients. And that coaching turns out in that study to be most important for practices that are not independent and small. They're more important for academic and health system practice. So I think that coaching mechanism is important, and it's authorized by the Affordable Care Act and the Primary Care Extension Program. So I think there's an opportunity there to build that support in as well.
And I think to add to that, people feel and revert to fee-for-service when they don't trust the payer. And what we need to do here is so I think that the next step will be bringing the payers into the effort so that there is a sense that everybody is at the table, that the issues are that are necessary to restore trust are built into this initiative. Otherwise, people will just revert to fee-for-service, even though they hate practicing under it because of the lack of trust. So this I think is going to be a major task of initiatives going forward. How do we build trust? And that means risk adjustment. Means adequate new investment. That means a pay raise for primary care clinicians, and it means a decrease in reporting burden. It's very interesting that what we learned from CPC and CPC Plus, and also Primary Care First, is that a major barrier is the reporting burden in payment mechanisms. And I think we're going to have to be very savvy in how we don't solve the accountability issue by having a new documentation burden built in. But I think we can develop that trust. I think we need everybody at the table. And I think Ann's organization has been terrific in getting figures together, but also states have, because the payers will say there's an antitrust barrier to our getting together. And when it's done at the state level through the governor's office or the secretary, the antitrust this issue is waived, and have everybody have a safe harbor to have these conversations. So I think we can get everybody together for a very productive, serious, trust-built initiative. And I think it's not only possible, it's essential.
Okay, thanks very much, Alan. Zuri, can I invite you to make a few comments? Zuri Song, who was already referred to, I think, as Alan Gorel's former student and now member of his practice, is also a specialist in health policy and on the faculty in the Department of Healthcare Policy at Harvard Medical School. Zuri?
Thank you, Russ. It's a privilege to be here with all of you. Listening to all of the wonderful points that have been made, I wanted to just offer a few additional points, I think rooted in the history and the mechanics and the economics of payment reform that might help transition the vision that has been so well laid out into a higher likelihood of becoming reality. And it builds on many of the points that have already been made. And so I'll enumerate these points from a simple 1 through 5. The first being that setting the global payment amount is really critical. And this report obviously champions global payment, whether in a hybrid model first or in a full-scale global payment model for organizations that are ready. But within the payment setting amount for a global budget, there are going to be two components involved. One is the current set of services under the fee schedule that are priced based on RVUs in the way that Carrie described. In that part of the budget, another distortion that is going to be baked in, especially for the commercial insurance market, is pricing differences due to market power. And how one might solve that conundrum to move towards equity is both incredibly important and also challenging. In the second part of the pricing of a global budget or payment are those non-fee-for-service, non-fee schedule services that we believe are important for enhancing primary care. Those include behavioral health integration, as has been noted by a member of the audience, social workers built into the practices, as has been shown in randomized trials to improve care and slow spending, and addiction medicine, especially for these days in the delivery system. These types of non-fee-for-service investments are also very important to price. And we don't now have in our current day a fee schedule that guides payers on what dollar amounts to attach to those non-fee-for-service based elements of primary care. So that's point number one, is the pricing of the amount of the budget. The second is this level versus growth concept. In all of healthcare spending, what gets nations and states and employers and insurers and indeed families and patients into trouble is not necessarily the level of healthcare spending, though that is very important, but it's more important the growth often of that healthcare spending. The growth rate, obviously over time as it compounds, builds in more fiscal pressure for constrained budgets than necessarily a level at a given point in time. So how the capitation for primary care grows over time, how a global budget or bundled payment or a global payment grows over time under a particular payment model is, I believe, potentially more important than setting that global payment in the first place. Whether that global payment growth rate is rebased year after year, or whether a multi-year contract is signed with providers so that they don't have to worry about rebasing, builds in lots of potentially intended and unintended consequences for whether providers enter or exit. And whether that growth rate is going to be in part based on historical spending and growth rates of that particular provider group or primary care practice, or whether that's going to be based on the regional averages that emerge, is also very important for the incentives that are laid forth in front of PCPs. Point number three is this collaboration. As Dr. Perrin mentioned, one of the audience members, who are the allies for primary care in this process? I think it's incredibly important to think through the specialists in the hospital communities that may or may not support increased investments in primary care. And importantly, whether that support hinges upon potential slowing or decreases in their own sources of revenue. In state budgets, which must be constrained and must be capped because states cannot run budget deficits and cannot necessarily deficit spend like the federal government can, healthcare spending increases mean decreases in other avenues of social spending, education, roads, bridges, and other issues. And so if an increase in primary care investment were to take place, how do states balance that with decreases in other services. This inherent redistribution is critical to think through. And for redistribution to be successful through a political process at the state level or any policy process that involves these stakeholders, one has to imagine that primary care needs allies among specialists and hospitals who may see a small slowdown, even if it's incremental, in their own revenue streams in order for primary care to see an increase in their investment. Point number 4 is on risk adjustment. And though this gets into the weeds quickly, I just want to mention that risk adjustment typically is thought of as adjusting a prospective payment for age, sex, clinical diagnoses. Those are the components of current day risk scores used by Medicare and private insurers. But there's fairly good evidence emerging that in primary care, we may not need to adjust for clinical diagnoses to have a viable risk score that adjusts the global payment. Perhaps age and sex alone at the demographic population level is enough to have a support for the global payment that justifies differentials between providers. That leaves out the question of whether there should be socioeconomic status or other social determinants of health adjustment on top of the clinical risk adjustment. And in that area, the evidence is not as well built. And so policymakers and payers have a real opportunity here through moving towards prospective payment for primary care to think through what elements of adjustment truly are needed and are appropriate for primary care, given that all sorts of clinical diagnoses for specialists and hospitals that might be more important for total global payment may not necessarily apply to primary care. And finally, the last and 5th point is this issue of voluntary versus mandatory. Within our CMS programs to date, in the last 10 years of payment reform, CMS has rolled out roughly 50 to 55 payment and delivery system reform programs, most of them largely voluntary. With voluntary payment models, which one might imagine in an initial phased approach towards payment reform might be more attractive to not only public payers, but private payers as they try to convince providers to move in this direction, do involve necessarily the opportunity to exit when a provider sees less promise or less certainty on the horizon. We have seen in the CMS experience, which they themselves, the policymakers at CMS have very nicely documented, that under voluntary payment models, when the future looks less certain, when prospective payments or risk-adjusted payments seem not to match what would otherwise be the fee-for-service revenue, providers are very quick to exit from ACO programs, from bundled payment programs, and from other delivery system reforms that are not dissimilar in spirit to what we're talking about here with primary care. So a key question is, should these types of payment models be mandatory for some, voluntary for others, mandatory for all, voluntary for all? That is a critical consideration. I want to commend the committee, my wonderful colleagues, Carrie, Bob, and others who contributed to this effort. It's really inspiring, again, for a student of primary care, past, present, and future. I look to resources like this for inspiration and continued learning. So I want to congratulate the committee. I want to thank Russ and the Center for Primary Care for holding this event, as well as the Ariadne Labs with Asaf for bringing this to the public forefront.
Thank you so much. That was very helpful. I know we're very close to time. I did want to give Florence Fee an opportunity to ask her question. Florence is an important advocate for patients with behavioral health concerns. Florence, do you want to unmute yourself and ask your question? Yeah, perhaps I could just read it for her. How do we move patients to make an active choice to go to practices offering HQPC, especially including medical and behavioral health care? Make it possible by resolving shortage areas and by removing payment insurance barriers, build models with behavioral health, engage community, don't wait for them to come, and build trust. I think, Bob, you had an answer to that.
I think you just read my answer, Russ.
I read your answer. I'm sorry. I was reading instead of the question. Yeah. How do we move? But she asked, how do we move patients to make an active choice to go to practice and avoiding HQPC, especially including medical and behavioral health care? delivered in a coordinated fashion from an interprofessional care team. Thanks.
My first two responses were really just based on the fact that we don't have those sufficiently, and particularly in areas where they're most needed. Once we overcome those, I think this is where engaging the community becomes important. Having social workers, community health workers, or others in the community who can identify patients who need those services can enable us to reach out to them. And in those, those patients often have issues with trust, and so getting them into a relationship that can over time build trust and be therapeutic is so critical. And that means, our recommendations linked to everyone having the capacity to have a usual source of care and to have those relationships becomes more important. But I welcome other ideas.
Let me maybe at this point ask Asaf Batan, who's both a member of the research faculty of the center, executive director of Ariadne Labs, and a member of the committee, to make a few comments in closing. Asaf?
Thanks so much, Russ. Thanks to all those who've gathered, and to Dean Daly for really hosting, I think, an important next step in a report that's really about implementation. And I'll just try to answer the question that Aaron Farron put up by way of kind of making three very brief closing or semi-closing remarks, which is, in this tension that we have around whether parts of the report, especially around payment, go far enough to either, move toward a model of full risk-adjusted capitation. And I think there is some convergence amongst many in academia and policy that it might be good. I think that the report and the theory behind the report, it's important to emphasize the following, which is this idea of mutual non-exclusivity. What do I mean by that? It is mutually non-exclusive for a strategy around payment to be both bold and far-reaching in terms of full risk-adjusted capitation, especially at a state level or at a large market level, like in Massachusetts, where there is catalyzed by Wayne and his group and the center and so many other groups, real momentum toward important, proximate, specific changes in primary care payment. And this idea that we have to start somewhere next week. The market and the provider landscape for primary care is extraordinarily heterogeneous, and there is no one group of actors that you can go tell the payers to move toward full risk-adjusted capitation next week, next month, next year, because there are so many payers. So the question here with the report, and I think where we want to think about, especially our state-level actions, or how can we think boldly, widely, and shoot for the moon while also building the struts to make it easy to implement tomorrow a form of payment that actually enables primary care to survive in the short term and thrive in the medium and long term. And I think that's an issue. If some of you have read the Heath brothers book on how to make change and how to make it stick, you have a rider and the elephant problem. We often have taken a concept that if we build the perfect model, if we make a perfect speech, if we write the perfect editorials, we will then get policy change to move. But primary care policy, healthcare policy is really an elephant problem. How do you get the elephant, of which the rider only sits on top and barely controls that elephant? How do you build an implementation pathway to make it easier for the elephant to actually take us where we want to go? And there you start in multiple tranches, you use redundancy, and you shoot high, but you also aim for what's possible tomorrow by changing the most corrosive parts of fee-for-service, by eliminating the power of the RUC to enact certain fee-for-service mechanisms that are not working today, but also not making a bet on the fee-for-service chassis, moving to a high level of capitation in a hybrid model, eventually phasing it all out, phasing the fee-for-service all out so that we can actually build that fiscal space for flourishing, team-based, community-oriented primary care to happen. That will require continued testing, tinkering, and specificity at the state and local level. And I think in the Massachusetts context, we have a wonderful opportunity with some of the pending legislation to really take those bold next steps and provide a model for other parts of the country to look at and copy the parts that appear helpful and innovate around the parts that they need to make specific to their own context. Thanks, Russ.
Thanks so much, Asaf. I really appreciate that. Well, thank you very much again to all the speakers, to those who who responded, to those who wrote the report. Again, thank you to the committee that authored this terrific report. And thank you to all of those who tuned in for this session. It is recorded, so we will be sending links out and expect that many additional people will see it as well. But thanks to you who participated in the conversation. What's really, just to reflect very briefly, unique in my mind about this report, or there are several things, but one is the discussion about primary care as a common good. I think in many ways that changes the conversation and really points out that primary care is something that leads to improved length of life, improved quality of life. And as such, we should think about it like we do education in this country, and we need to find better ways of funding it, supporting it, and making sure that everyone has access to it going forward. The second thing that's really unique is really the implementation strategy, which I think is very clearly defined in this report, but I think depends really on all of us becoming advocates for the goals of this report and thinking about how we can work together with either our professional organizations, the authors of the report, and others to really make these goals a reality. I think our country, really depends on it. It depends on us and what we're able to do to really implement the recommendations of this report. So I look forward to hearing about what is to come, to participating, and hopefully joining with all of you and moving the goals of this report forward. So thanks again, and thanks for joining us. Have a good day.